Hello friends, today's topic is hypoxic ischemic encephalopathy. Heart disease. He came with chief complaint of breathing difficulty. In view of breathing difficulty and desaturation, patient had cardiac arrest, lasted for 20 minutes and revived after that. On arrival in ICU, his pulse rate was 89, blood pressure was 143 by 89, respiratory rate was 19, SpO2 was 100, PR with maintaining with the maintaining on the PRVC mode with FiO2 of 40%. On serious examination, H1 H2 normal, RS air entry equal on both side, per abdomen soft, CNS E1 VT M1. So patient was diagnosed with the hypoxic ischemic encephalopathy and will understand the pathophysiology behind this. So the post-cardiac arrest brain injury is the main cause of death in the patient resuscitated from the cardiac arrest and the main cause of long-term disability in those who survive in the acute phase. So in this lecture, we will describe the pathophysiology of the post-cardiac arrest brain injury, its management in the critical care setting, and how this post-cardiac arrest brain injury severity can assess to predict its prognosis. So this post-cardiac arrest brain injury pathophysiology is encompassed by the primary, that is ischemic insult, and secondary, that is reperfusion injury, which occurs sequentially during the cardiac arrest, resuscitation, and acute post-resuscitation phase. So primary injury, cardiac arrest results in the cessation of both cardiac output and oxygen delivery to all vital organs. There is no flows phase starts upon the onset of cardiac arrest and lasts until the partial reperfusion is established by cardiopulmonary resuscitation. Brain receives 15 to 20% of total cardiac output to maintain the tissue homeostasis. Brain tissue viability strongly depends on the consistent supply of the oxygen and energy substrate, namely glucose, and cessation of the cerebral blood flow results in the immediate interruption of the brain activity. In human study demonstrated that consciousness is lost between the 4 to 10 seconds of absent cerebral blood flow, while EEG becomes isoelectric after 10 to 30 seconds of asystole. Due to their lack of inherent energy stores, neurons are particularly vulnerable to ischemia, and cellular damage starts immediately upon the absence of the cerebral blood. At cellular level, uh, ischemia results in the cessation of the aerobic metabolism with the consequent depletion of the high energy substrate adenosine triphosphate. ATP depletion results in dysfunctional energy dependent sodium potassium ion exchange pump action, which leads to the massive influx of sodium and water and intracellular cytotoxic edema. Potassium efflux and the membrane depolarization also ensued shortly thereafter, leading to the opening of the voltage sensitive calcium channel and intracellular calcium influx. Experimental evidence shows that the signs of brain edema on MRI develop already during cardiac arrest and resuscitation. Now about secondary injury. Upon initiation of the CPR, CBF cerebral blood flow is partially restored, but it that is from no flow to low flow, but it remains suboptimal to sustain neuronal integrity as CPR generates approximately 25% of normal cerebral blood flow, substantially below 40 to 50% of normal cerebral blood flow needed to maintain the cellular integrity and avoid additional ischemic injury. With return of spontaneous circulation, cerebral blood flow is restored, but the reperfusion of ischemic cerebrovascular bed triggers a series of mechanisms leading to the secondary brain injury. The intracellular calcium increase caused by primary injury leads to release of the glutamate, an excitatory neurotransmitter that binds to cell membrane, causing the further intracellular calcium influx and cytoplasmic accumulation from the endoplasmic reticulum. Subsequent activation of calcium-dependent lytic enzyme, that is proteases, phospholipases, exacerbate the neuronal damage. Calcium-dependent mitochondrial dysfunction also ensures, leading to cell energy failure and release of pro-apoptotic proteins and reactive oxygen species, which resulting further neuronal damage. A further component of reperfusion injury is the activation of innate immune system and subsequent tissue inflammation. This is initiated both by resident macrophages known as macroglia and circulating leukocyte which adhere to the endothelial cell of the cerebral microvasculature and migrate into neuronal tissue. Additional release of cytokine from the activated leukocyte further amplifies the inflammatory response. Leukocyte migration is facilitated by increased permeability of the blood-brain barrier, which also leads to the vasogenic edema. Cerebral perfusion changes in the post-cardiac arrest brain injury. Like in flow situation, in experimental setting, reperfusion of the brain after transient global ischemia is incomplete and inhomogeneous. This phenomenon is called as the no reflow and histologically appear as a multifocal perfusion defect of the brain tissue. The number and extent of this perfusion defect increases with the duration of ischemia, while their distribution coincides with the anatomical location where post-cardiac arrest brain injury is most commonly detected, like striatum, hippocampus, amygdala, and thalamus. Now, delayed hypoperfusion in animal model, return of spontaneous circulation is followed by transient increase in the global cerebral blood flow, after which delayed hypoperfusion occur. In patient with the post-cardiac arrest brain injury, cerebral blood flow may decrease by more than 50% during this phase. The role of delayed hypoperfusion as a cause of post-cardiac arrest brain injury is unclear, and studies in comatose resuscitated patients have shown that both cerebral metabolic rate of oxygen and the cerebral oxygen extraction fraction also decreased 24 to 72 hours after cardiac arrest, suggesting that coupling between cerebral blood flow and oxygen demand was maintained. Oxygen extraction rate were significantly lower in patients who died from post-cardiac arrest brain injury. It is not clear, however, if this resulted from the reduced oxygen utilization due to mitochondrial dysfunction or irreversible brain injury or due to reduced oxygen delivery to the brain. Recent clinical studies made using the intraparenchymal microcatheter reveal the presence of the brain tissue hypoxia. Measured as parenchymal brain tissue oxygen tension below 20 mmHg in the half of the comatose patient with the post-cardiac arrest brain injury from 13 to 40 hours post-arrest. Patient with the brain tissue hypoxia showed the active release of the biomarker of neuronal injury in the jugular venous blood, while those without brain tissue hypoxia did not. Changes in the cerebral autoregulation. Generally, cerebral blood flow is considered to be stable over range of the mean arterial pressure, although considerable heterogeneity is noted in healthy women. This property is termed as cerebral autoregulation. Cerebral autoregulation is narrower or right shifted in approximately 30 to 50% of patients after cardiac arrest. Consequently, arterial hypotension after cardiac arrest may result in cerebral hypoperfusion, which leads to the worsening of the post-cardiac arrest brain injury. In the post-resuscitation care, these changes in the cerebral autoregulation represents potential target for optimizing cerebral perfusion. Now the next is intracranial hypertension. There is accumulating evidence that patient with the post-cardiac arrest brain injury may develop intracranial hypertension. Increased intracranial pressure likely results from the cytotoxic and vasogenic edema and is associated with the poor neurological outcome. Increased intracranial pressure shortly after admission to intensive care unit was a strong predictor of the poor neurological outcome at 3 months. Treatment of the post-cardiac arrest brain injury. At present, there is no direct treatment for post-cardiac arrest brain injury, and as such, secondary injury to the brain should be minimized by maintaining physiologic homeostasis. Derangement in the temperature, arterial blood pressure, oxygenation, and ventilation should be avoided. Optimizing cerebral perfusion. The optimal arterial blood pressure target after cardiac arrest to mitigate post-cardiac arrest brain injury from secondary ischemic injury is not. In 2019, the Neuroprotect trial randomized 107 comatose patients resuscitated from the cardiac arrest to undergo either protocolized goal-directed hemodynamic optimization, that is mean arterial pressure of 85 to 100 mmHg, and mixed oxygen venous saturation, that is 65 to 75%, and targeting map of 65 mmHg using fluids, inotrope, and vasopressor at discretion of the treating physician. So result shows no difference between the two group in the percentage of ischemic brain volume quantified using MRI, nor in the rate of good neurological outcome at 6 months. Instead of the standardized blood pressure target, authors have advocated for maintaining MAP within the individual patient's range of intact autoregulation to optimize cerebral perfusion. To that aim, the two derived parameters have been investigated. The first is cerebral oxygenation index, which is correlation between cerebral regional oxygen saturation and measured using near infrared spectroscopy and MAP. The second is the presence reactivity index, which is the correlation coefficient between intracranial pressure and MAP. And increasing this COX or PRX with MAP suggests that dysfunctional autoregulation, while a near zero or negative value of COX and PRX suggests the autoregulation is intact. Based on that model, the optimal map is the range corresponding to the lowest value of COX or PRX. At present, however, neither of these indices have been assessed prospectively in clinical interventional studies, and there is no consequences on what is optimal technology to individualize brain pressure target in brain injury. The current guidelines on the post-resuscitation care, co-issued by the European Resuscitation Council and European Society of Intensive Care Medicine, do not suggest any specific blood pressure target, but recommended to avoid hypotension and targeting MAP to achieve the adequate urine output and normal or decreasing lactate. Now, regarding oxygenation, hyperoxia is potentially harmful because it may increase the production of the free oxygen radical and worsen the post-cardiac arrest brain injury. In the experimental setting, ventilation with 100% oxygenation after cardiac arrest results in the worst neurological deficit score with histological evidence of greater post-cardiac arrest brain injury severity. However, results from the large clinical observational studies have been conflicting, with studies showing that hyperoxia defined as arterial partial pressure of oxygen more than or equal to 300. And it was associated with significantly greater hospital mortality than normoxia, that is PO2 between 60 to 300, and other studies showing the no association. In 2018, the COMCARE trial randomized 120 comatose survivor of out-of-hospital cardiac arrest to normoxia to moderate hyperoxia for 36 hours after ROSC. And there was no difference observed. No difference was observed in primary outcome measure and the blood level of neuron-specific enolase as a marker of neuronal injury at 48 hours from the return of spontaneous circulation. A recent post-hoc analysis of 166 patients enrolled in multi-center ICU ROCKS trial, which randomized 1,000 patients to conservative and the liberal oxygen therapy, showed that conservative oxygen therapy was not associated with significant decrease of odds of survival with poor neurological outcome at 6 months. The exact trial randomized 1,016 resuscitated comatose survivor of out-of-hospital cardiac arrest to restrictive and liberal oxygen therapy. And the current ERS ESICM guideline on post-resuscitation care recommended avoiding both hypoxia and hyperoxia, maintaining pulse oximetry within the safe range of 94 to 90. Now, the next parameter is ventilation. Cerebral blood flow is partially regulated by partial pressure of carbon dioxide in arterial blood flow. Low or high PCO2 decreases or increases cerebral blood flow due to cerebral constriction and vasodilation respectively. In patients with the post-cardiac arrest brain injury, hypocapnia from the excessive ventilation may reduces the cerebral blood flow, potentially worsening ischemic injury. And in patients with the traumatic brain injury, hypocapnia increases both oxygen extraction fraction and volume of the brain at risk of ischemia. Alternatively, hypercapnia may cause cerebral vasodilation and increase ICP, and there is evidence that ICP may be increased in some patients with post-cardiac arrest brain injury due to cerebral edema as described above. However, moderate increase in cerebral blood flow from mild hypercapnia may potentially improve cerebral perfusion after resuscitation and may be beneficial. Mild hypercapnia was evaluated clinically in two small clinical trials, both using blood flow or blood levels of NSE as their primary endpoint. The coma care trial randomized patients to the low normal versus high normal PCO2, low normal that is 34 to 35 and high normal that is 44 to 45 during the first 36 hours after ROSC. And NAC neuron-specific analysis did not differ between the two groups. However, high normal PaCO2 was associated with inconsistently and significantly higher level of RSO2 measured with the near-infrared spectroscopy. This result suggests that the increased cerebral oxygenation and perfusion from high normal PaCO2. So the CCC trial randomized patient to the normocapnia and mild hypercapnia for 24 hours, and hypercapnia was associated with significantly lower increase in NSC over the first 72 hours. So based on this pilot trial, a large randomized control trial team is currently comparing the two treatment arms in the 1,700 comatose resuscitated patients. So, in the absence of robust evidence for benefit or harm from mild hypercapnia, ERC, ESICM guideline recommended titrating ventilation in order to maintain normal PCO2 level that is 35 to 45. Now the next is targeted temperature management. Targeted temperature management refers to any strategy that aim to achieve and maintain any specified body temperature ranging from 33 to 37 degrees Celsius. This usually involves the core temperature measurement probe in the bladder and esophagus and feedback controlled surface cooling device and intravascular catheter. In experimental literature, the neuroprotective effect of hypothermia are consistent across the model and species, but the significant heterogeneity among studies make it difficult to conclude on optimal timing, dosing, and duration of the treatment. Mild systemic hypothermia to 32 to 34 was rapidly introduced into clinical practice in 2003 after publication of two clinical trials reporting improved survival and neurological outcome in out-of-hospital cardiac arrest patient with ventricular fibrillation as initial rhythm treated at 32 to 34 for 12 to 24 hours. Subsequently, the dose-finding study have not shown significant benefit from pre-hospital cooling or longer duration of cooling to 48 versus 24 hours. In 2013, TTM trial did not show any difference between cooling to 33 degrees Celsius compared to 36 degrees Celsius in patients resuscitated from out-of-hospital cardiac arrest from presumed cardiac cause. In 80% of 939 patients included in this trial, the initial rhythm was shockable. The HyperON trial, who enrolled 581 patients with non-shockable rhythm, that is asystole or pulseless electrical activity, resuscitated from out-of-hospital cardiac arrest or intra-hospital cardiac arrest to TTM at 33 degrees Celsius versus 37 degrees Celsius. The trial showed similar mortality but significantly higher rate of good neurological outcome among survivors in the hypothermia group. However, this trial had the fragility index of only one, meaning that if only one patient in the 37 degrees Celsius group had CPC had the had this CPC, the trial would not have been significant. In 2021, the result of TTM2 trial were presented, and TTM2 randomized 1,900 patients with out-of-hospital cardiac arrest of cardiac or unknown cause from all rhythm to TTM at 33 degrees Celsius versus TTM to 37 degrees Celsius in case of fever defined as more than or equal to 37. So result shows that TTM at 33 degrees Celsius had no beneficial effect or signal thereof on mortality, functional outcome, and quality of life at 6 months. And it was associated with significantly more arrhythmias with hemodynamic instability. Two subsequent meta-analyses have concluded on the lack of effect of TTM compared to normothermia on survival or functional outcome and possible harmful effect by moderate to deep hypothermia. Based on the evidence, the International Liaison Committee on Resuscitation had issued the updated treatment recommendations suggesting that active prevention of fever for more than or equal to 72 hours by targeting temperature of less than 37 instead of previously recommended target of 32 to 36 degrees Celsius for more than 24 hours for those patients who remain comatose after cardiac arrest. And international scientific societies will implement this recommendation in their updated guidelines. Since recommendation to actively prevent fever and use cooling devices are weak and based on low certainty evidence, randomized trial targeting fever prevention are urgently needed. Now the next is neuroprotective agent. Pharmacological approach to mitigate secondary injury following ROSC can be compartmentalized into intervention aimed at mitigating excitotoxicity, improving neuronal metabolism, limiting mitochondrial injury, and neuroinflammation. Recently, interest in xenon gas, an inhibitor of N-methyl D-aspartate receptor, has emerged as the potential therapeutic agent in limiting excitotoxicity during a reperfusion phase. Letio et al. Conducted randomized controlled trial of 110 out-of-hospital cardiac arrest patients and demonstrated reduced white matter injury on MRI in patients receiving xenon versus those without. However, there was no difference in 6-month clinical outcome. In the ZAPE POCAST trial, which is randomized out of hospital cardiac arrest, which in this they have randomized out of hospital cardiac arrest patient to 50% xenon inhalation during TTM versus without, and has completed enrollment and awaiting the publication. Additional therapeutic approaches targeting the mitochondria function and metabolism using thiamine, pyruvate, and ubiquitol are at currently preclinical phase and have not yet studied in the phase 3 design. Finally, immunomodulation approaches aimed at mitigating the neuroinflammatory cascade have have generated attention, and the Cyrus trial, which is again they have randomized out of hospital cardiac arrest patient to receive cyclosporin versus placebo in the 794 patient, but did not demonstrate difference in clinical outcome and organ dysfunction score. Now, next is control of seizure. Clinical seizure occur in one-third of patients with post-cardiac arrest brain injury treated in ICU or may be of epileptic and non-epileptic origin. Myoclonus is dominating manifestation, but generalized or focal tonic-clonic seizure are also common, often occurring in same patient. EEG is crucial to confirm that clinical seizure is related to the cortical epileptic activity, since seizure mimics are common in ICU and since the use of sedative and muscle relaxant suppress the clinical manifestation of seizure. EEG is also useful to prognosticate outcome and follow the effect of the treatment. Seizure causes the metabolic stress and are associated with the poor neurological outcome after cardiac arrest, providing a rationale for the treatment. However, it is unclear whether the seizure causes further brain damage or whether they simply are the marker of severe post-cardiac arrest brain injury. To date, there is no direct evidence that anti-epileptic treatment improves the outcome of post-cardiac arrest brain injury. The Telstar trial, which is randomizing patient with status epilepticus after cardiac arrest to either medical treatment to suppress all electrographic seizure activity and no treatment, and may provide useful evidence to answer that question. So current guidelines suggest that treating post-anoxic status epilepticus with sodium valproate and levetiracetam as first-line agent in addition to the increased sedation. However, prophylactic anti-epileptic treatment is not recommended. The usual sedative agent used in ICU have anti-epileptic effect, and this should be kept in mind since the seizure often manifests as sedation is weakened. Thank you.